Hello, my name is Matilde Soares, and I am here today to talk to you about the guidelines on the classification of foot ulcers in people with diabetes from the WGDF. I am the secretary of this group that is composed by 8 people from Australia, UK, Thailand, America, and Portugal, myself, and also with different clinical expertise. Also, I would like to acknowledge that these recommendations will also not be possible without the help from external reviewers from several countries and also from 2 patient representatives. First of all, I would like to start by defining what we will be discussing. So when I talk about a system, classification or scoring system, I mean any system that attempts to create more homogeneous groups of patients for which similar levels of care should be provided and to standardize the modifiable factors that one should focus on to improve clinical outcomes. We believe that these systems should be used in 5 different scenarios and purposes, and these remain the same as 2019. So for communication among healthcare professionals, for predicting the outcome of an ulcer in a specific individual, for characterizing a person with an infected ulcer, for characterizing a person with peripheral arterial disease, and for the audit of outcomes of populations. And we have the opinion that no system is still able to fit all of the purposes at once. To develop these recommendations, we have used a thorough grade methodology approach. We started by establishing a diverse expert panel and then to define key clinical questions. And also for that, we needed to define critically important outcomes. They were grouped in 4 broad categories, and they were clinical outcomes, post-baseline clinical outcomes, usability, and use of resources. And all of these outcomes were discussed and rated by the group elements, external experts, and people with diabetes representatives. And we came up with 5 different clinical questions that should address 13 critically important outcomes. We started by undergoing a systematic review. We're making the summary of findings for each system, then to rate the certainty of evidence, to make the summary of judgments, and then to identify what would be the systems that we would be able to recommend. And only then to pass to the later stage of selecting the best system or systems for each of the selected purposes. So one of the main differences was that in 2019, with our critical review, we have found 19 classifications addressed in 50 studies. But in 2023, undergoing our systematic review, we found 28 classifications addressed in 149 studies. Having all the aspects that I've been discussing addressed and evaluated, we have selected only those that we felt we could conditionally or strongly recommend. And this selected 6 out of the 28 available classifications. And the ones that we felt that we could recommend its use on clinical practice would be DIAFRA, IWGDF, Simbad, University of Texas, Wagner, and Wi-Fi. Then we have compared the summary of judgments among each of the 6 final systems, and for each of the 5 selected purposes, we choose the best one, and if possible, also an alternative system. And we can see in this table which were the judgments that we had to do based on accuracy, certainty of evidence, certainty of effects, resources, cost effectiveness, equity, acceptability, and feasibility. And we can see in green those that were considered as positive judgments, meaning they would support the use of the system. In red, those that would not favor the use of the system. And in blue, neutral judgment that we could not select and believe that was a balance between supporting or not the use of the system. And as you can see, they are very heterogenic, and so we needed to look carefully based on the purpose that we were looking for. So what were the recommendations that we have made? The first one is that in a person with diabetes and a foot ulcer, you should use the Simbad system for communication between healthcare professionals about the characteristics of an ulcer and clearly state the presence or absence of each of the composing variables. And this recommendation is same as in 2019. As you can recall, the Simbad is built upon 6 different variables, and they are dichotomically categorized as being absent or present. And so for sight, we would believe that a worse prognosis is linked with midfoot and infoot. The presence of ischemia is based on clinical evidence of reduced pedal flow. Protective sensation lost would be the item based on the presence of neuropathy, if there is bacterial infection or not, if the ulcer is smaller or has 1 square centimeter or more of its area, and if the ulcer reached the muscle tendon or deeper. And please have in mind that each of the items should be described as absent or present, and not to use the total score for the communication between healthcare professionals. But one of the changes that we've made is that in addition to Simbad, you can also use Wi-Fi for this purpose of communication about characteristics of an ulcer between healthcare professionals. However, this should be used when resources exist in addition to an appropriate level of expertise and if it is considered feasible by the context where it should be used. Wi-Fi is based on wound and on its depth, and also if there is the presence of gangrene and its extension. The presence of ischemia based on ankle brachial index, ankle systolic pressure, or TCPO2. And foot infection using the IWGDF categorization that has 4 grades, being the 0 considered as no symptoms or signs of infection, and 3, the worst, that is an infection that is at the systemic level. We still believe, the same as 2019, there's still no currently available classification or scoring system should be used to offer an individual outcome prognosis for a person with diabetes and a foot ulcer. In a person with an infected ulcer, then we recommend the use of the IWGDF. Please have in mind that we only have evidence available for the 2015 version, which have in mind that this is a little bit different from what is recognized and supported by the Infection Working Group Guideline, but for its clinical management. The IWGDF, as I've told you, has these 4 different grades and are the same as the ones used by Wi-Fi. And so, again, one of the things that we have considered is, again, if you have resources and if you have an appropriate level of expertise and it is considered feasible, you can consider using the Wi-Fi system because it has the IWGDF embedded in it, but then you have even more detail about ischemia and also the wound characteristics. In a person with diabetes, peripheral artery disease, and a foot ulcer, you should consider using the Wi-Fi system as a means to stratify healing likelihood and amputation risk, and this is the same as 2019. For the audit, regional, national, or at international level, we still recommend the use of the Simbad system score. So in this case, you should use the total score to allow the comparisons between institutions on the outcome of people with diabetes and a foot ulcer. So in sum, we had 7 recommendations developed, 5 remained unchanged, but we added new. And these two news are considering for the communication and characterization of a person with an infected ulcer to use the Wi-Fi as an alternative system when you have resources and expertise. And all of the 28 systems showed low or very low certainty of evidence. And so we believe that research should focus on validation and optimization of the existing systems and also on prognosis of individual outcomes for which no system was able to be recommended. Thank you very much for your attention, and feel free to contact us if you have any questions or comments.